Great. Hi again, ladies and gentlemen. Welcome back. My boss, Kelly Appenzeller, told me I have to get this ball rolling again, so here we go. So I just want to say, first of all, if you all have been standing in the back, there are still a few seats. Hopefully people found seats during the break. There's still a couple seats up front, so please do come and find a seat. Also, in case you didn't notice, there is like a rumbling under the room. That is the metro. That is not an earthquake, in case you were worried. All right, but so we're going to go ahead and get started. I am really thrilled now to introduce the moderator for our keynote discussion. And that person is Allison Hamblin. Allison is Senior Vice President at the Center for Healthcare Strategies. And I should say, this is the last time I will be introducing her as Senior Vice President because in just a few short weeks, she will be taking over as President and CEO at the Center for Healthcare Strategies. So congratulations, Allison. All right. And Allison has specific expertise in the areas of physical and behavioral health integration, alternative payment and delivery models for people with complex needs, and return on investment. So I'm really pleased that she's here today to lead a discussion with Dr. Lisa Fitzpatrick about how underlying social and cultural challenges can lead to worse health outcomes for certain populations. So Allison, welcome. Thanks.
Hi, good morning, everybody. Thank you, Sarah. Can you hear me okay? Okay, great. Well, it is my pleasure to be here with you all today, and I have the privilege of introducing Dr. Lisa Fitzpatrick, who will be joining me on stage in just a moment. Dr. Fitzpatrick is a CDC-trained medical epidemiologist. She is also a board-certified infectious disease physician with extensive public health experience in both domestic and global settings. She is the founder and CEO of Grapevine Health, which I hope she will tell us more about in a moment. And she is also a professor at the Milken Institute School of Public Health at George Washington University. So without further ado, Lisa, please come join me on stage. Hi. A cozy little setting for us here to have a personal, quiet little chat.
I didn't even know this room was here.
So for those of you who have looked at your agenda and seen the title of this session, which is Social Determinants of Health, Holy Grail or Dead End, this actually is borrowed from the title of a blog that Dr. Fitzpatrick wrote for Forbes recently, late last year, I believe, in which she talks about the need to go beyond attempts to address individual social needs and to focus rather on larger underlying community needs and community dynamics. You talk about things in the blog like food literacy, which is a phrase that we haven't heard yet this morning. We've heard a lot of interesting conversation, and I'll be happy to have you take us there in a moment. You talk about a real pervasive lack of trust in the healthcare system. That is a major dynamic at play here that needs to be attended to. And you also talk about how for many, making a choice to go to the doctor can pose some real threats to job security. And sometimes people are perhaps making very rational choices when they do not show at a doctor appointment. Just to quote you for a moment, if I may, from the blog, you say, achieving population-based shifts in health outcomes for low-income communities requires moving beyond text message reminders, Uber rides to clinic visits, and vouchers for farmers markets and food pantries. These shifts demand bold and transformative steps to address poverty by providing education, economic opportunity, and a pathway to lifelong economic stability. So you throw down the gauntlet there, and I think that's why you're here today.
Yeah.
So I wanted to start us off by having you just talk a little bit about your journey and how you arrived at this very strong conviction you have around the importance of health literacy and health equity.
Yeah, well, first of all, thank you for being here. It's really nice that folks are taking notice of the things I write about because I think they're so important. I've been thinking about this for over 20 years. When I was working at CDC, we conducted a lot of investigations in low-income minority communities. And the same issues I wrote about in the blog years ago resonated then as much as they do now. So I started doing a lot of community outreach and volunteering to talk at churches and in community settings. And at one meeting I went to, I was on a panel, and on this panel with me were pretty high-powered people. David Satcher was on the panel. Louis Sullivan was on the panel. So I was a little bit intimidated, but the audience was from the community. And they were asking very basic questions like, my doctor said I have diabetes. Does that mean I can't eat pork anymore? So my answers were very basic, and they were in the language people needed to understand. So after that meeting, a man walked up to me, and he said, how does someone like me access someone like you on a regular basis? And that stuck with me because it meant that he was hungry for someone to talk to him about his health in a way that no one has spoken to him before. So I've been thinking about it since then, and took several detours before now, focusing squarely on health literacy. But I think a lot of the lessons I learned in community, it reinforces my conviction that we have to figure this out. Because if we can't communicate to people in the way they need to be communicated to, it only deepens their distrust. It's like speaking a foreign language. If you can't understand what someone's saying, they're not going to trust you.
Yeah. And if you don't mind, tell us a little bit more about the issues of trust, because you write and you talk a lot about this, right? So part of it is, do you speak to me in a language I understand, and do I feel comfortable as a peer asking you the questions that I really want answers to? And part of that may be a broader history, and so I'm just curious sort of where you
wow, there's a long, long history, and I'm sure there are a lot of people in this room who understand some of this history. We talk a lot about the legacy of distrust in healthcare related to studies that people know about, like Tuskegee, and I think the book about Henrietta Lacks recently has recharged conversations around the distrust, but it's not just that. Because if you talk to people nowadays, especially younger people, they don't even know what Tuskegee is. What they're distrustful of is the reasons they're distrustful is because of their own experiences in healthcare. Being disrespected, having people talk down to them, going into a clinic and then having to wait an hour when you had to be on time.
Right.
So those kinds of things are fueling the distrust. But also, there is history in the community around disenfranchisement. And people recognize that. And so that continues to go on in our healthcare system with people not getting the kind of care, access they need, even right here in DC. And if you're a Medicaid patient, sometimes you can't get the subspecialty care you need. And I had a woman just last week tell me she wanted to get her health care at a specific hospital, but she couldn't because she had Medicaid. So when those things happen, the Grapevine lights on fire. And they tell people about, well, we get inferior care here because we have Medicaid and they won't let us go here. And all of these myths, whether they're true or not, it doesn't matter, because if the community perceives they're true, then that's what matters. Yeah. And that's where the distrust is really impacting our ability to improve health outcomes and really engage people in healthcare.
So Grapevine, so you've thrown it out there. So tell us about Grapevine Health, and specifically tell us about what you're trying to do, and whether through Grapevine or elsewhere in your experience, what type of interventions and strategies are working in community to help get better information out there to folks?
So a few years ago, because of my passion around health literacy, I started beta testing a video series called Dr. Lisa on the Street. Has anybody seen it?
I have.
One or two people? So Dr. Lisa on the Street was my effort to educate people or see if you could get people's interest around a health issue while engaging them in a funny conversation while they're learning at the same time. And I abandoned that because I went to work for Medicaid. And at Medicaid, some of the things I've been telling you were reinforced through the data. DC is a great example. We have a $3.1 billion Medicaid budget, but we have some of the worst health outcomes in the United States. So why is that? What's happening with the disengagement? So then I started thinking about Dr. Lisa on the street, what I was learning, and what might be the next step. So I conducted a study last summer, and one of the questions we asked people was, where do you get health information you trust? We asked them about their healthcare experiences, but that was one of the final questions. And most people said, well, I just Google it. And I said, well, what happens when you go to Google? Do you know what to do then? And they'd say, no, I usually just go and ask my grandma, or I'll ask my mom. And one person said, well, my uncle was in the hospital. He had a stroke, and he was in the hospital for 2 weeks, so he's our family health expert, so I go and ask him. So what that was telling me, that people trust their friends and family with health information more than they trust us, and that's a problem. So the purpose of Grapevine Health is to not discount those conversations and that information. There's really great information being passed in the community around health. But a lot of times it's not accurate. So we want to insert medical people like myself in those conversations. But we also want to get insight so that we can help Medicaid programs better conduct outreach and reach their populations. There was a paper that came out in Health Affairs a couple of months ago, maybe not even that long ago. But it suggested that Medicaid programs don't understand how to engage their members because they were giving incentives for a variety of things, and the incentives were being either left on the table or people weren't doing what they were asking them to do with the incentives. And this is not just one or two Medicaid programs. It's many Medicaid programs participated in this study. And what that told me is that there's an opportunity to figure out how we can help Medicaid programs understand what's driving some of the behavior and the disengagement in a way that they're clearly not able to. So that's what we do.
And so I would imagine this involves partnerships, right, with other organizations in the community. Or so how are you actually making that work? Do you have any sort of examples in any local community?
Ooh, with a lot of blood, sweat, and tears. But our biggest partner right now is the United Planning Organization, and they're an organization who helps with job placement, job training, but they also disseminate the SNAP benefits. So being able to have access to an organization like that, and this is the same population that we're interested in serving, it's a natural collaboration. So we're in the early stages of that, and we're talking about how we can interact with the SNAP beneficiaries, most of whom are also Medicaid beneficiaries, and having listening sessions with them. The first one we had, people suggested we needed to do a cooking contest. And I love this idea because all the information will come from them about what constitutes a healthy meal. And I'd like for one of the requirements to be, you can only use food that you get in your neighborhood. And make it a healthy meal, and then we can put that on social media and let people vote. So we're having conversations like that, really trying to get at the core issues that are challenging the programs in the health system in reaching folks.
Yeah, that's great. So in a number of the conversations earlier today, we've talked about, or a number of clinicians acknowledged that things have changed so much since when they went through medical school, and that folks weren't talking about social determinants of health and so forth. You know, if you think about these issues of health literacy, what needs to happen in terms of how we train our healthcare workforce differently to make individuals and make our healthcare workforce more attuned to these issues that are so fundamental?
I appreciate you asking this question. I think this has to start in medical school.
Yeah.
And I know the curricula are crowded, but this, I think, is an imperative because I have countless stories of students and residents who are not communicating with patients. They think they're communicating, and then I come in the room, and then I hear a completely different story. And some of that, I think some of that is related to style, some of that is related to comfort level, but there are some pretty egregious stories around this. And I think if we don't embed this in the curriculum, as they say, when they're young, it will be very difficult once they're out in practice to focus on things like health literacy and even care about distrust. I can't overstate how important it is. I also think residency programs, there are plenty of opportunities to expose residents to people like me. I'm not the only person who thinks this way. There are people in our institutions all across the country who think this way. But giving them a platform and an opportunity to be in front of residents and instilling this kind of information and way of practice into the ways they're being trained.
Yeah. And, throughout healthcare, there's an increasing focus on team-based care, right? And on leveraging different types of health professionals and allied health professionals in different ways. An earlier panel mentioned community health workers, for example. And how do you see kind of the team as part of this work and opportunities to leverage other roles?
It's really essential. We have a really small team right now. Mostly that's a function of funding, but the community health worker model is critically important. I love it. In fact, I don't think we're using them at the top of their license. I think community health workers and family members can actually be trained to do so much more, to be the eagle eye when something's going on or something is just starting, and they can be attuned to know, okay, we need to call someone, or you need to go and have an evaluation. So we're missing a lot of those opportunities. But I think the community has to also be part of it. So that's why for Grapevine Health, the video content we'll be producing, all the conversations, they actually start from the community. And I think what's unique about the approach we're taking is if you look at most of the innovation that's being built now or pushed out to people, we're building them, number one, for profit. So we're thinking about profit first. How do you make money? But then we're building them for the health system, for health teams, and then pushing that out to the community. Why don't we flip that and figure out what the community wants first, ask them to help you design it or build it, and then introduce it into the health system. And that's what we're trying to do.
Yeah.
It'll be really hard, but it's so far, the insights we're getting just from being in the community on the ground are really validating the need for us to have a solution that's more outward facing. Because then it also addresses the HIPAA issue. People keep asking me, well, what about HIPAA? Because we want a digital solution eventually to be connected to the work we're doing. If the patient initiates the conversation, why are there so many concerns about HIPAA? Because the person is already giving you permission and access. So it's been a very enlightening journey.
I think Dr. Wisdom said earlier, the answers are there in the community. It's our job to go out and talk to people and find the information. And I have time for one last question, so I'm going to go back to your title, your compelling title, right, for the blog and this session again. As we think about all of this effort around the healthcare system looking to address and do a better job of attending to individual social needs, are we looking at a holy grail or are we looking at a dead end here?
So the example, I'm not sure which example I used in the blog, but let's just talk about food, because food is really important to me. And our solution right now, we need to screen for social determinants. If we recognize that someone is food insecure or they live in a food desert, then we need to figure out how to get food to them. I think we're ignoring two big, and I'm just using food to make a point, which is a broader point, I think, for all of the social determinants. If you give people food without asking them what kind of food they want, what kind of food they like, This is, and I'm summarizing this because this is what people have told me. Why are you bringing this box of food? I don't recognize this food. I don't even like that food. Why aren't we teaching them how to cook? I've had people ask me to tell them what an eggplant looks like and how you cook with an eggplant. Food literacy is so critically important because it's the parable about giving a person a fish, versus teaching them how to fish. And I would love to see us focus more of the social determinants lens in that direction rather than giving things to people. We're trying to help them, but what they need is support.
Right.
So I could go on all day about that, but since we're out of time, you can email me or poke me on Twitter and we can talk more about it.
That's great. Well, Dr. Fitzpatrick, it was brief but enlightening, so thank you so much for sharing your thoughts with us.